Hi everybody, and welcome to 4526, Week 2 or Class 2, Part 1. Today we're going to speak about airway, breathing, circulation, and disability, and we'll go in the order in which I have them here. You may have been introduced to this concept of organizing and prioritization in the past. I assume you have by this point, but we're going to go over it in a little bit of a greater detail and look at advanced measures to promote ABCD. So let's start off with airway. Oftentimes I find students get confused between airway and breathing. So to clarify the difference, airway refers to the upper respiratory tract. So you can see here the upper respiratory tract is the nasal cavity and the different areas of the pharynx. So the nasopharynx, the oropharynx, and the laryngeal pharynx. And the upper respiratory tract just stops above the stops just at the level of the larynx or just above the thyroid cartilage. So right here. And then we have the breathing. So breathing takes place in the lower respiratory tract, but especially within the alveoli. And that is exactly where gas exchange takes place. So when we refer to the airway, we're referring to the nasal cavity and the pharynx all the way down just to the beginning of the end of the larynx right here. So when we're doing an assessment, we want to do a quick assessment. And we would do an ABCD, and we do this quickly to assess the clinical status of the patients that we're taking care of. And this way we can prioritize our management quickly. So the information I'm going to give you about assessment under the individual components is the minimum amount of what needs to be done quickly. So remember, this is our quick check. After we do our quick check and we find out if our patient is either stable or unstable, then we can intervene right away for the appropriate category. And when they are stable, we can go back and take a closer look at each of the systems separately. So we start with airway. And the reason we start with airway is because without an airway, quite frankly, you don't have a patient. If the airway is not patent, air cannot get in and there will be no gas exchange, and therefore there's no purpose for circulation. So let's go back to airway. When we assess airway, the first thing you want to ask yourself is the airway patent? In order to assess this, we want to look to see if our patient is talking. If they're talking, then the airway is patent simply because air is moving over the voice box or the larynx, and if there is air getting past there, the airway is patent. We want to observe for the presence of swelling and drooling, and these are indications of an obstructed airway. Other ways to assess for your patient quickly is they may have paradoxical or uneven chest and abdominal movements. What about their skin color? Is it blue or mottled? You could listen for signs of obstruction. So for example, noises such as snoring, expiratory wheezing, or gurgling may indicate a sign of a partially obstructed airway. Listen and feel for airway obstruction. If the breath sounds are quiet, then air entry should be confirmed by placing your face or your hand in front of the patient's mouth and nose to determine airflow. By observing the chest and the abdomen for symmetrical chest expansion or listening for breath sounds with a stethoscope. And we'll get into that when we do our more of our assessment. So what are some of the potential obstructors? So if the airway is in fact obstructed, we want to think about potential obstructors. When we look at patients with different disease processes in the acute care setting, we want to think about potential obstructors in relation to what they are presenting with. So we're looking for secretions, mucus and vomit, swelling, and the tongue. These are all potential obstructors. An example of secretions would be a pneumonia or bronchiectasis, patients who have copious amounts of secretions coming from their lungs, which could potentially obstruct their airway. Mucus and vomit might occur if someone is post-op and they're taking medications for pain, which may lead to decreased level of consciousness and maybe vomiting from anesthesia. Airway swelling, of course, can obstruct the airway, and the best example of this is with anaphylaxis. And of course, the tongue can obstruct the airway by the tongue falling backwards and blocking it. And so, as you can see here you can see the tongue falling back and blocking the airway. And we often see this with our stroke patients and patients who have decreased level of consciousness and our seizure patients. So let's talk about interventions for airway. So our go-to is always manual maneuvers. So you have the head tilt chin lift for a stable cervical spine and the jaw thrust for an unstable cervical spine to maintain neutral alignment of the neck. So here we have the head tilt chin lift. Suctioning is right here. Suctioning is always airway's best friend. In any acute care hospital, you must be sure to have working functional suction at the head of the bed. It needs to be clean as well because airway is one of the absolutely necessary things that we as nurses need to manage. So it's one of your checks that you do in the morning if you're working in an acute care setting. An option to manage an airway that's not going to resolve quickly or maybe prolonged would be a nasopharyngeal airway, which is here. This goes into the nares and sits at the back of the tongue. We also have an oral airway that goes through the mouth. And then we have advanced airway management is right here, and this is an enterotracheal tube. This is the ultimate airway management. It will keep the airway patent and allow long-term management. By long-term, I mean maybe up to a week, and management of somebody's airway until we can resolve the issue. Usually when we perform endotracheal intubation, we're also talking ventilation, so a mechanical ventilation, and we'll talk about that next in part 2. So just to give you an idea, so this is a picture of an oral pharyngeal airway. And just a little bit about how you measure for an oral airway. So you can see this is at the lips, and you measure it to just the back of the jawbone. That's the proper sizing. So you want to ensure you have the proper sizing. So it's really important to measure these accurately. If it's too short, it will not unblock the airway. And if it's too long, it could cause further obstruction. This is the right way to put it in. Now they're saying an older child, but this is also the way you put it in for an adult. So you put it concave up first, you slide it in. When you reach the back of the throat, you turn it around and you have your airway in place. This is a nasopharyngeal airway. And as you can see, it goes through the nares and actually sits at the back of the tongue as well. And inserting an airway, again, you need to select the airway, you need to select the proper size, and you measure the individuals from the earlobe to the tip of the nose. You lubricate the nasal airway, and you insert it in the right nostril with the bevel down towards the middle of the nose, and you advance the airway gently until the flange rests on the nose. Now, whether you go in the right or the left, I don't really recall a reason why there is a difference, but anyways, either way, you can go in either nares. Maybe there's one that's obstructed for some reason. And then just a little bit about pillows. No pillows. So you cannot manage an airway with a pillow under the patient's neck. It automatically provides some flexion. So if there's no cervical spine issue, the neck should be hyperextended a bit. So let's move on to breathing. So as I said before, breathing involves the alveoli, gas exchange. Gas exchange is the diffusion of oxygen through the alveolar membrane in exchange for CO2. And as I've said here, the breathing function, or when we come to the B, should only be assessed after the airway has been judged as adequate, because we can't be able to ventilate a patient without a patent airway. So, assessment. Remember, we're assessing breathing quickly here. So remember, this is our quick assessment. So we start off with the rate, depth, and rhythm. You must do all three. I'll give you an example. You may have someone with a respiratory rate of 12, which is completely normal, but their depth may be shallow and they may be having rhythm issues, so periods of apnea. And so their saturation is going to be quite low. And if you only looked at the rate, you would classify this individual as normal. And so rate, rhythm, and depth, all three. Look for accessory muscle use. So the heaving of the shoulders, the abdominal muscles will be used. you'll do a quick listen to the lungs. And a quick listen means 4 spots. You're going to do the upper lobes by listening to the second intercostal space, mid-clavicular line on each side. And then to listen to the lower lobes, you're going to listen to the 5th intercostal space, mid-axillary line. And you're listening on both sides, and you're listening for crackles, wheezes, and air entry. You'll also use a pulse oximeter, and remember the pulse oximeter is your SpO2, so it's only measuring the peripheral oxygen saturation, and it's the saturation of hemoglobin molecules with oxygen. And this is versus a more deterministic saturation when you do a blood gas and you get your SaO2, which is your arterial saturation. Typically, you want the saturation to be 94 and above, but if you've not learned already, our COPD patients actually require a lower amount of oxygen, and we'll get into the reasons behind that when we speak about different types of respiratory issues. So you need to assess the saturation according to the patient context, but for the most part, you want it above 94. So interventions. The first one is positioning. So if the patient is supine, it just makes sense that you want to raise the bed to be semi-Fowlers or high Fowlers for lung expansion and better ventilatory capacity. Coach breathing. This is helpful in COPD patients. We want to maximize expiration, so they breathe in 2 seconds and they exhale over 4 seconds. And we want to do this to maximize exhalation to clear out the accumulation of carbon dioxide in the alveoli, which can lead to patients with COPD. A little bit about oxygen. So there are different delivery systems. Here I have nasal prongs, and here I have a Venturi mask. So oxygen can be delivered differently depending on the situation. For nasal prongs, depending on where you work, but typically you would not go above 6 liters, so anywhere from 2 to 6 liters. 2 liters equals 24%, and 6 liters equals 40%. So how you calculate this is you go up by 4 liters for every percentage. So for example, 2 liters is 24%, 3 liters is 28%, 4 liters is 32%, 5 liters is 36%, and 6 liters is 40%. Now, for someone who's a mouth breather, you might find that a mask is more beneficial. And so, as I've said here's an example of a Venturi mask. So Venturi masks have different color-coded mixers that change the oxygen concentration, and it can be anywhere from 24 to 50%. And anything above 50%, typically you need to call the respiratory therapist for the next step. Other ways are bronchodilators. So bronchodilators dilate the airways. And so this is great for your asthma and COPD patients, and it's often given through a nebulizer mask. BiPAP is over here, so you can see this external mask. So BiPAP is very much like an external ventilation. So it adds positive pressure and oxygen during the inspiratory phase to force the air in. And we're going to speak a little bit more about this when we speak about ventilation. And then lastly would be your intubation and ventilation. And ventilatory settings accommodate for what the patient's lungs can't do themselves. And stay tuned for part 2 when we speak about that. So let's think about if you've got a patent airway, but the patient is not breathing. So what are you going to do next while you're waiting for intubation? So you can have all the oxygen you want, but if there's no ventilation at the alveolar level, there's no point of oxygen. And so the AMBU bag, or your bag valve mask, or your bag mask valve, there's different acronyms, provides ventilation needed prior to intubation and ventilatory support. And so it's really important that you have proper positioning, a snug fit, and you hook the high flow oxygen to you hook this to high flow oxygen to inflate the bag. So this is proper positioning. So this is called the CE positioning. You've got the thumb and the index finger making a C, which is holding the snug fit of the mask. And there's different sizes of masks, but typically there's like a small and a large adult, and then there's a child version and a pediatric version, or an infant version. Anyways, you have the C and the E. This is the CE positioning. So CE, this is your C, and then your E is here holding the chin in the proper alignment, and then your other hand is compressing the bag here. And so the rate is really important. Again, you do not want to give any more than 12 ventilations in a minute. So that's 1 ventilation every 5 seconds. I find that people give too much and they oftentimes hyperventilate because it's often a time where it's very high anxiety of what's happening with this individual. But I want you to think about this: you count 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000, ventilate. 2, 2, 3, 4, 5. So I want you to think about the ventilation. It's really important. And there's a lot of repercussions for intracranial pressure related to hypo and hyperventilation related to CO2 lectures. And related to CO2 levels, and we will speak about that in another lecture. So next is our circulatory system. And remember that assessment of circulation should only be undertaken after the airway and breathing have been assessed and properly treated. And so what you're doing here is you are assessing the circulatory system to determine the effectiveness of the cardiac output. And so that's the volume of blood ejected from each heartbeat. So how do we do that? Well, the first thing you can do is through assessment is look at the skin color. Is it pale, dusky, cyanotic? Are they flushed? What's the temperature? If they're cool, they're vasoconstricted. If they're warm, they're vasodilated. That could give you an indication of shock. The skin turgor is very important to assess for dehydration. Cap refill is very important. You want it to be brisk and about 2 seconds. So the normal value for cap refill is usually under 2 seconds. So what you do is you hold the nail bed down for about 5 seconds to blanch, and then you release it and you watch, and you want it less than 2 seconds. If it's delayed, there's poor perfusion. The pulse, typically the pulse ranges, again, a normal pulse is 60 to 100, but really everyone has their own normal resting pulse. So for example, if you are on metoprolol or a beta blocker, your resting pulse may be anywhere from 56 to 60, but we often see tachycardia during stress and shock. And then again, blood pressure, the normal again is 120 over 80, and there's lots of variation. You could have a high blood pressure, which indicates pain or anxiety, or a low blood pressure indicating hypovolemia. Maybe they're bleeding, or maybe they're going into a shock situation. So interventions. Again, positioning. So if someone has a low blood pressure, do we want them sitting in high Fowlers? Probably not, because gravity is going to be working against us if we're trying to perfuse the brain. So you want to lie them flat. But especially if breathing is not great, then you're going to have to make a compromise between having the bed up a little and having them flat for their blood pressure. So maybe semi-Fowlers or somewhere between 50 to 30%. Fluids, again, you need IV access. So typically what happens when you are assessing someone quickly, someone may be assessing A and B, and the other person is putting in an IV access. So fluids, typically normal saline is the go-to for someone in a compromised state. If blood loss, typically you would get packed red blood cells. If post-op, it's usually Ringer's lactate. The drugs would be your advanced cardiac life support drugs, so your ACLS drugs. Dopamine is often given because it's a peripheral vasoconstriction and it increases the contractility of the heart. That increases the cardiac output and blood pressure. But most importantly, you need to address the underlying cause. So if somebody's bleeding, we need to address the cause of the bleeding. If someone is dehydrated due to vomiting and diarrhea, we need to address the cause of that. And so, yes, we want to replace the fluids and give drugs as appropriate, but we need to understand the underlying cause to be more specific. So always address the underlying cause. And this may be something that's done not during your quick assessment, your initial quick assessment, but maybe the second part of your assessment. And then we have disability. And so this assessment involves reviewing the patient's neurologic status, and its assessment should only be undertaken once A, B, and C above have been optimized, and as these parameters can all affect the patient's neurological condition. So assessment. With disability, we are addressing what's happening in the brain. We're specifically talking about perfusion to the brain, because once perfusion to the brain goes, remember, it's the organ that controls everything. So we need good perfusion to the brain. Poor brain perfusion issues can lead to decreased level of consciousness, which can lead to obstruction of the tongue for the airway. So in that way, disability and airway are linked. So again, yes, it is the fourth thing that we're looking at after ABC, but it needs to be identified because maybe it's the underlying cause. So assessment of disability, we're looking at the standard neuro exam. So we're doing a quick one here. So one mnemonic is AVPU, looking, is the patient alert? Do they respond to verbal stimuli? Do they respond to painful stimuli? Or are they unresponsive? Vital signs are important. If someone is hyperthermic, so a high temperature, it can lead to changes in the level of consciousness as well as hypothermic. Cushing's triad looks at 3 different types of vital signs. So Cushing's triad indicates an increase in intracranial pressure. And the 3 things that you will see are increase in systolic blood pressure, a decrease in pulse, and a decrease in respirations. That, as you know, will give you an idea that there could be an issue with intracranial pressure. So is there a head injury? Is there a bleed? What's happening with this patient? And then lastly, the Glasgow Coma scale. Someone who is alert and oriented are going to be at 15. A GCS of 3 is basically a poor outcome unless there's a reversible cause like a drug overdose, which can be reversed, or a brain hemorrhage, which could be evacuated. And then below 8 is typically where we're concerned about airway, so we would intubate. So below 8, intubate. So this is the GCS score, which I'm sure you are familiar with. And then interventions for altered level of consciousness. So again, the priority is to assess airway breathing circulation to exclude hypoxia and hypotension, which could lead to altered level of consciousness. You may check the patient's medicine chart for any reversible medicine-induced causes of an altered level of consciousness. And then unconscious patients whose airway are not protected should be nursed in the lateral position. Now again, if their GCS is 8, typically you're going to intubate. And then just thinking again about ABCs when you're writing your NCLEX exam. So using the ABCs when selecting an answer or determining the order of priority. Remember, airway is always the first priority. So here's a question I want you to think about. So the client with a diagnosis of cancer is receiving a morphine sulfate 10 milligram subcutaneous injection every 3 to 4 hours for pain. When preparing the plan of care for the client, the nurse includes which priority actions? The nurse is going to monitor the stools, monitor the urine output, encourage the client to cough and take deep breaths, or encourage fluid intake. And if we think about the test-taking strategy of using ABCs, recall that morphine suppresses the cough reflex and the respiratory reflex. And so that is the importance of choosing something related to airway, breathing, and circulation first to prioritize. So coming up in part 2 is advanced airway and ventilation. So if you've got any questions about this first lecture for part 1, if you could please write down your questions and bring them to our Zoom class for week 2.